All right. Good morning, everyone. Welcome to another grand round session here at Temple Neurology and Neurosurgery. I'm Dr. Jan. It's my honor to introduce our guest speaker for today, Dr. Andrew Lee. Dr. Andrew is one of my favorite doctors, favorite educators. I've been following him on social media for like 6-7 years now, and he's a huge presence and a huge fan base in Singapore, London, and here in America as well. So formally, Dr. Andrew Lee is chair of the Blanton Institute Department of Ophthalmology at Houston Methodist, and is a professor of ophthalmology, neurology, and neurosurgery at Weill Cornell. He is adjunct professor of ophthalmology at Baylor College of Medicine, University of Iowa, University of Buffalo, and clinical professor at University of Texas Medical Branch in Galveston, Texas, and MD Anderson Cancer Center. Dr. Lee has served on the national and international editorial board of 20 ophthalmic journals, including JAMA Ophthalmology, Survey of Ophthalmology, the American Journal of Ophthalmology, the Canadian Journal of Ophthalmology, the Japanese Journal of Ophthalmology, Journal of Neuro-Ophthalmology, and was the founding editor-in-chief of the Journal of Academic Ophthalmology. He has published about 700 peer-reviewed articles, 40 book chapters, and 10 full textbooks in ophthalmology. He has been invited speaker at about 500 national and international eye meetings and has given around 15 named lectureships. He has a special interest in resident education and in this connection has received the Resident Teaching Award 17 times at 5 different academic institutions. He has been consistently named in Best Doctors, Top Doctors, and was listed in Newsweek among the top 40 ophthalmologists in the United States. Dr. Lee lives in Houston, Texas with his 2 daughters, his ophthalmologist wife, Hillary, and their 2 cats, Lola and Miss Kitty. And there's a disclosure, I think I wanna share this. Dr. Lee has served as a consultant on neuro-ophthalmic conditions to the United States Department of Justice, NASA, and the National Football League. But the views expressed by Dr. Lee do not represent those organizations or the United States government. Thank you so much, Dr. Lee, for doing this. You can take over now.
Very good. So thank you first of all for having me. I'm sorry I can't be there in person. And I want to talk to you today about both the obesity epidemic and why pseudotumor cerebri is coming to your town. In fact, it's already in your town, and that every neurologist and every ophthalmologist needs to be a little bit of a neuro-ophthalmologist when you're taking care of pseudotumor cerebri. You actually don't have to do neurop. You don't have to like neurop. You don't have to like me, but you have to RESPECT neuro-ophthalmology. You're about to find out what that means to me. And I do have these other disclosures, which have nothing to do with this talk, Horizon, AstraZeneca, and Bristol-Myers Squibb. And if you want to know more about anything that I'm talking about today, even though I know this talk is being recorded, please come visit me at Nodal Neuro-Ophthalmology with Dr. Andy Lee. It's free. I will not be discussing any off-label uses of drugs. However, I'm going to talk about acetazolamide diamox, which is an approved drug. So IIH, I want to tell you about something old, something new, something we borrowed, and then something blue. And hopefully at the end of this talk, you'll be an expert in neuro-ophthalmology for IIH. And so my goals today are to talk to you about something old that we already knew about, an old disease, pseudotumor cerebri, way back to the dandy days of the modified dandy criteria. The something new is the treatment trial and stenting, and we borrowed that from endovascular, of course, and something blue, which is always make sure that the patients don't have obstructive sleep apnea, which causes increased intracranial pressure from both hypercapnia and the obstructive component of forced expiratory effort against the closed glottis. But before I get started, I want to start with a question, which is, are you really prepared for the epidemic of pseudotumor cerebri that is coming? And what should you be doing both on an intellectual level, but on a practical level at your own institution for dealing with pseudotumor cerebri, including the emergency version of it, fulminant IIH. And of course, it's not just the United States that's experiencing the obesity epidemic. It is a worldwide phenomenon. And only in America would this guy, he has a little towel here, take the escalator instead of going up the stairs to the 24-hour fitness center. And advertising definitely impacts the epidemic. And you can see here it says childhood obesity, don't take it lightly, but right underneath, aimed at the same demographic in the same neighborhood and in the same at-risk population, the counter message. And obesity is already a huge problem. You can see what it looked like in 1980s. It was uncommon to find obese people, but by 2002, it was a significant minority. And when you get couch potatoes and too much screen time and fast food, you get the descent of man. And this is just to show you what it looked like in 1985 in the United States. This is obesity trends amongst US adults. And you can see the color scheme here. 14% is this dark blue. So it was already here in 85. This is 86, 87, 88, 89. New categories created now for Mississippi, West Virginia, Louisiana, the whole South, Texas. Now new category created for 20% obese in the United States. That's 1997, which is many years ago now. The whole South, including Texas, Mississippi, 25%, Alabama, West Virginia, the whole South, new category, Louisiana, Mississippi, that was 2005, 1 in 3 adults, the whole South, the whole country. And by 2030, 42% of Americans are going to be obese. And by 2050, it's probably going to be half the country, 42%. So it's already here. And if you look at the world map of obesity, 40%, you can see that the United States is not alone in this. And all of these countries here are facing rates of epidemic proportion, in addition to the whole Western world, Australia, New Zealand, South Africa, Chile. And part of the problem is our sizes have gone out of whack. So when I was a kid, you could buy a tub of popcorn, but it was like this big. And now it looks like this. And you can see the associated calorie counts. If you go to Starbucks and you order a mocha with whip and just have 2% milk even, that's 330 calories compared to what coffee costs and what coffee has in it, 45 calories. Slice of pizza. And if you look at the original 8-ounce bottle of Coca-Cola, and I can't even finish this 20-ounce thing when I get it at lunchtime, and you can see that's going to be a problem. So this obesity epidemic is bringing to you something that's super dangerous for a neurologist, because papilledema, number one, it's getting more and more difficult to recognize it with just the direct ophthalmoscope. So you need ophthalmologists to help you in this regard, because we can perform the dilated exam and the formal visual field. And papilledema has a differential diagnosis. So we reserve the name papilledema for increased intracranial pressure related disc edema. Every other form of disc edema, you should probably just call it optic disc edema, because what's in a rose by any other name would still smell as sweet, but papilledema means increased intracranial pressure. So that name is super important to us, and everything else should just be disc edema. And as you know, usually it's not that hard to tell them apart. Papilledema, any age, of course, optic neuritis, young person, AION, non-arteritic and arteritic, anterior ischemic optic neuropathy, older people. But papilledema, unlike those optic neuropathies, normally has preserved central acuity, is bilateral. It produces only a big blind spot or perhaps a nerve fiber layer defect like a nasal step. And they have concomitant symptoms of increased intracranial pressure, headache, nausea, vomiting. They might have diplopia from a non-localizing 6th nerve palsy. So the key and differentiating features from the get-go, if we see a unilateral decreased acuity, decreased field, RAPD, relative afferent pupillary defect, and visual field defect in a young person, we really should be thinking about optic neuritis, and that's MS, the MS mimics, and the MS-like illnesses, including NMO and MOG. And in an older patient, non-arteritic anterior ischemic ophthalmopathy, but rule out giant cell, that's the arteritic AION. And so that is all old. So the something old is everyone knows you're supposed to check the blood pressure because malignant hypertension, hypertensive emergency can totally mimic papilledema. That's grade 4 hypertensive retinopathy is actually optic neuropathy. Neuroimaging study, and in the modern era, we need an MRI with contrast and head and orbit with MR venogram. You might be asking why we need the orbit, and that's to rule out the finding that excludes papilledema, which is optic nerve enhancement. So we need the head and the orbit for all disc edema patients to make sure there's no contrast enhancement of the nerve, and an MR venogram to rule out sinus thrombosis. And of course, we need a lumbar puncture with opening pressure to ensure that the CSF content is normal and confirm the diagnosis. These are the modified Dandy criteria for idiopathic intracranial hypertension. Symptoms of increased intracranial pressure. Signs confined to increased intracranial pressure. MRI only showing the radiographic findings of increased intracranial pressure, flattening of the globe, fluid in the sheath, empty sella, venous sinus stenosis, but no thrombosis, and a lumbar puncture can only show increased intracranial pressure on opening pressure, normal CSF content. That is the Dandy criteria, and Dr. Dandy would probably say that sounds right to me. And the reason the acuity isn't decreased usually in papilledema is it's slow flow, not no flow. It is exoplasmic flow stasis, and because the subarachnoid space is contiguous with the optic nerve sheath, the CSF pressure from the head can be transmitted right down the optic nerve. This leads to the buildup at the level of the lamina cribosa. And one of the things you need to know is a dead nerve can't swell. So if there's optic atrophy already, we got to be careful. That definitely needs to see ophthalmology. And we have machines that can help us with this differentiation called optical coherence tomography, OCT. And papilledema is rarely unilateral. So if it's unilateral, then you should be thinking optic neuropathy, young person, optic neuritis, old person, AION. Of course, the typical symptoms of increased intracranial pressure, headache, often postural, or it can be worsened with Valsalva, cough, straining, nausea, vomiting, and then transient visual obscurations lasting seconds at a time. So even patients who are being admitted to the stroke service, for example, for what you think is amaurosis fugax from an ischemic etiology, cardiogenic, cardioembolic, or carotid, you still need to look in the eye for papilledema. So it's typically described as lasting seconds at a time, transient, graying out of the vision, and can be postural, going from the lying to the sitting position or coming from those positions. And they often describe it as transient flickering, lasting seconds at a time. The diplopia is from a non-localizing sign of increased intracranial pressure, sixth nerve palsy. And so normally the visual acuity is preserved because slow flow doesn't really affect your visual acuity. It's not no flow. And the acuity can be decreased if we have macular hemorrhage, macular edema, macular exudate, or if we have chronic disc edema. And in the acute setting, we could have fulminant IIH. So if the acuity is down, they definitely need to see ophthalmology, have a visual field, and be evaluated because there are different causes for decreased acuity other than just the papilledema itself in IIH. Of course, we're going to do a formal visual field on that person, automated perimetry. And the most common field defect is a big blind spot, because as you know, the optic nerve is your blind spot because there's no photoreceptors there. And so a big blind spot is the most common feature that we see on the visual field for papilledema. But because the axon is being compressed by intracranial pressure, it causes nerve fiber layer loss. And so it looks like glaucomatous visual field loss because intraocular pressure and intracranial pressure both affect the optic nerve at the lamina cribosa, and they tend to cause the same type of field defect. And as I mentioned, the non-localizing sign of increased intracranial pressure, either unilateral or bilateral sixth nerve palsy, that's from increased ICP, sixth nerve gets stretch, and that doesn't tell you where the lesion is, and thus it's non-localizing. And in fact, there can be sometimes no lesion That's idiopathic intracranial hypertension. And the optic disc edema, if it's from increased ICP, we call it papilledema. Now, you should know that we do look for this spontaneous venous pulsation, but only in iffy cases. And you should be looking at it right at the disc head. The fluctuation in the systolic blood pressure and the collapse of the pressure wave relative to the increased intracranial pressure, which is the opposing force, leads to the spontaneous venous pulsation on the disc head. And so you can see if you flick back and forth here, just on that disc head right there, we can see the vein open, close, open, close. So it's really great if you take the direct ophthalmoscope and look right there. Of course, even if you meet the modified Dandy criteria, you still need to exclude malignant hypertension, the hypertensive emergency. And so all patients with papilledema need to have their blood pressure measured. And you need to ask about the medicines that cause it. Long list of medicines. You should definitely go Google that. The most common are lithium, tetracycline, vitamin A analogs, including topical isoretinoic Accutane. And steroids are listed in the list, but it's usually steroid withdrawal, not steroid onset, that causes IIH. The most common and the highest proximal causation to worsening or development of IIH is weight gain. And as you know, these patients are typically young, obese females of childbearing age. We have to do that venogram. You need a V to find the V. The V we're looking for is venous sinus thrombosis, VST. However, a lot of patients have venous sinus stenosis, VSS, and that's just a known radiographic finding of increased intracranial pressure. In patients who have venous sinus thrombosis, we're going to do a hypercoagulable state workup. You should know that the thrombosis doesn't have to be in the head. It can be in the jugular vein, not just the cerebral venous sinuses, after radical neck dissection or any kind of line placement in the jugular. And even though birth control pills are listed as a cause for IIH, it's usually from venous sinus thrombosis, from the hypercoagulable state associated with the birth control pill that causes it. Just the birth control pill alone probably isn't causal. And even though in the emergent setting, you're going to do a CAT scan, which is faster for looking for causes that are emergent of increased intracranial pressure, blood, trauma cases, calcification, or if you're just looking for hydrocephalus, of course, an MRI with a contrast MR venogram is better than a CAT scan. And so the standard of care for papilledema, unless there's a clear contraindication, is MRI, head and orbit, with gadolinium contrast, and an MR venogram to make sure there's no sinus thrombosis. You need that V, venogram, to find that V, venous sinus thrombosis. There is no V in MRI or CT. And I prefer a contrast MR venogram if possible. And if it's an iffy case, we're going to switch to CTV after the MRI and MRV. So here's just a typical case of papilledema. You can see there's the obligatory fundus findings, peripapillary nerve fiber layer hemorrhages, little tiny cotton wool spots, obscuration of the nerve fiber layer as the blood vessels cross the margin. And we have a grading scale called the Friesen scale. And if it's 360 degrees like this, we call that grade 2. And if there's obscuration of the major blood vessel as it crosses the margin, we call that grade 3. And if every vessel is blocked, then we call that grade 4. And so if it quacks like a duck and looks like a duck and flies like a duck, also known as the modified Dandy criteria, it's probably a duck, idiopathic intracranial hypertension. So my dad would say IIH is a duck if it has only symptoms of increased ICP, only signs of increased ICP, only radiographic signs of ICP, and the lumbar puncture only shows elevated ICP. All that means is it's a duck. But if it doesn't quack like a duck and doesn't look like a duck or doesn't fly like a duck, it's probably not a duck. And so IIH is a diagnosis of exclusion. You have to follow the modified Dandy criteria. Which brings me to that obesity thing again. You're very familiar with the typical IIH demographics: young, female, obese, BMI over 30. And so there are 5 ways that we can kind of blow it with IIH. Number 1 is not recognizing that the atypical cases need to be admitted and have more expedited evaluation. That's fulminant IIH. Fulminant is defined as acute and severe. It's both acute, less than 2 weeks, and it's severe, defined as loss of central acuity or visual field loss that's severe. And now you see why you have to work closely with your ophthalmology colleagues, because you need a Humphrey or automated perimetry visual field. You cannot rely on the CT. If you do an MRI, it has to be MRI, head, orbit, gadolinium, contrast material, and an MRV. And so we can miss it if we don't give the contrast, or we didn't do an MRV, or if you didn't operate right away on an acute severe vision loss, which is called fulminant IIH. So here's a patient who only had a CAT scan. The reason they only had a CAT scan is this patient had a non-MR compatible pacemaker. The CT and CTA were read as normal, but look, there's like 3 peas in a pod here. So you're supposed to have 1 carotid here. This is like 3 carotids. And this patient has this giant draining vein. And of course, it was not idiopathic. It was a huge dural arteriovenous fistula. So you should be very scared if you only have a CT. But if you're going to do a CT, do a CT contrast and CTV to make sure there's no venous sinus abnormality. And even though thrombosis is the thing we're looking for usually, it can also be thrombosis with or without a fistula. So a dural fistula will cause venous back pressure and venous hypertension. It'll look to you just like IIH. This is another case where we blew the diagnosis, not me, but somebody else. This is the MRI scan, but no contrast was given. And the arrow is there to remind you have to look at the sinuses. And of course, when you gave the contrast material when they came to our hospital, there's a mass there pressing on the torcula. So this patient was told she had IIH, but she has real tumor cerebri, not pseudotumor cerebri. The something new is not that new anymore, called the Idiopathic Intracranial Hypertension treatment trial. And in the trial, patients had to have parametric mean deviations between -2 and -7, which is moderate vision loss. And they were randomized to 2 treatment arms, placebo plus diet, or acetazolamide. And you can see that they were increased to maximum dose tolerated, and everybody, both sides, got low sodium weight reduction diets. And so they were monitored with automated perimetry at 6 months with a statistical comparison of Diamox, acetazolamide plus diet. Is it superior to placebo plus diet alone? The secondary outcome measures at 6 months were changes in the disc edema, quality of life, and change in CSF pressure. So here you can see the results. Mean change in parametric mean deviation, which is the visual field in the worst eye, acetazolamide plus diet against placebo, and you can see the difference in the curves here at 6 months, showing that acetazolamide plus Diamox was superior for visual field parametric mean deviation in IIH compared with diet alone. And if you look at the secondary outcome measure, improvement in CSF intracranial pressure, you can see placebo against acetazolamide. There's no question that acetazolamide lowered the intracranial pressure in the IIHT. And they looked at the Friesen scale for papilledema, nothing, a C-shaped halo, 360-degree halo of elevation, 360 degrees plus obscuration in the nerve fiber layer at the margin. The whole thing's obscured, and then everything's blurry. If you look at Friesen grade of papilledema, placebo versus Diamox, there's no question the mean change in Friesen grade was way better to a statistically significant and robust level with acetazolamide. So the IIHT, the Idiopathic Intracranial Hypertension trial, proved something we already thought we knew, which is acetazolamide improves visual outcome. The effect of the acetazolamide was independent of diet. Its greatest effect is in the first month, and therefore we normally wait at least a month before we even think about tapering the Diamox. And there was some secondary outcome measures here in terms of disc edema. You had a worsening prognosis if you had high-grade Friesen papilledema. Most patients were at 1 gram, 1,000 milligrams, and I would emphasize to you, please don't start too low a dose of the Diamox. So 1,000 milligrams is normally our starting dose, 500 milligrams twice a day, and you could go up to 2 to 4 grams. Most people cannot tolerate 2 grams or more, but some patients can go to as high as 4 grams. If you're starting to get into 4 grams of Diamox, you probably should be thinking about surgery at that point. There was no permanent morbidity from acetazolamide, and even though it is a diuretic and a carbonic anhydrase inhibitor acting at the proximal tubule, nobody needed really potassium supplementation. So here's a patient that just emphasizes some of the points that are problematic. This patient's 13. She had Ehlers-Danlos. She already had a Chiari malformation. You should know that the Chiari malformation alters the CSF dynamics. And even if you had a decompression like this patient, you could still have a problem with your CSF flow. She was given the diagnosis of idiopathic intracranial hypertension, and you should be very scared about giving the diagnosis of idiopathic to anybody that has pathology. This person already had the Chiari. Of course, her opening pressure was elevated, so technically she met the diagnostic criteria. An MRI shows normal, an MRV shows venous sinus stenosis. She had intractable headache on topiramate, and because of the EDS, the Diamox is a problem because of orthostatic hypotension, tachycardia syndrome. And so she was sent to consider venous sinus stenting. And so the thing that we borrowed from the stenting people is, this is the normal MR venogram with contrast, superior sagittal sinus, transverse, sigmoid down the jug. So that's a very beautiful anatomy. And the thing we borrowed and the thing that had to be used on this Diamox intolerant Ehlers-Danlos IIH with the Chiari was put a stent across that segment. So you can see the stenotic segment here. The placement of the stent opens the stenotic segment, and the opening of the stenotic segment, venous sinus stenting, is proving to be very efficacious. And in some centers, including Mayo Clinic, it's become the go-to procedure over shunting and over sheath fenestration because it lowers the pressure right away. And so if you want to read more about the debate about stenting of the transverse sinus in idiopathic intracranial hypertension, you can go to this point-counterpoint article in the Journal of Neuro-Ophthalmology. This is a graph showing the pressure gradient across the stenotic segment versus superior sagittal sinus pressure. So pressure across the stenosis versus superior sagittal sinus in 46 patients who underwent stenting. And you can see there's this wide array. And normally we require that you can't just have stenosis, you have to have a gradient. And for our hospital, that's 9, but it's variable. We need to have a gradient across the stenotic segment. And in the beginning, the debate was, is it the chicken or the egg? Is the venous sinus stenosis from increased intracranial pressure? And the stenotic segment is a Starling resistor, which means if you press on it, it collapses. And the stenosis leads to venous outflow obstruction, leading to secondary venous hypertension, leading to decreased CSF absorption, causing increased ICP. And because it's a Starling resistor, that further collapses the collapsible transverse sinus. And so the mechanism by which stenosis collapses the sinus, leading to intracranial hypertension, is thought to be that it is a Starling resistor. So here is a Starling resistor, the pressure ICP across the stenotic segment, transverse sinus to sigmoid sinus. And when the pressure is high, it collapses. The theory is that venous sinus compression leads to venous sinus stenosis, leads to venous outflow obstruction, leads to venous hypertension, and further decrease in CSF absorption, elevated CSF pressure, and it's like a loop. So maybe it doesn't matter whether it's the chicken or the egg. Putting a rigid construct stent across the stenotic segment might cure pseudotumor cerebri. And literally in the patients who have had this stenting procedure, they might have complete resolution of their headache and their pulse synchronous tinnitus right away. And it's a marker that we are resolving the pressure gradient. So here's the collapsible sinus, which is the Starling resistor, against a rigid sinus. You can see that the pressure modulation that occurs in a rigid sinus, in the collapsible sinus, the CSF pressure in millimeters of mercury, if you infuse CSF, the pressure goes up. And if you drain CSF, the pressure goes down. And if you infuse CSF, the pressure goes up, a Starling resistor. And now they're doing the same experiment with a model simulating the withdrawal of the CSF across a stented segment, a rigid sinus. So you infuse the CSF, the pressure goes up. However, once you put the stent across, even if you infuse and withdraw CSF, it doesn't change the pressure anymore because the stent is rigid and the stenotic segment ceases to be a Starling resistor. And it's interesting because some of these papers in the past have reported the venous sinus stenosis, and at the CSF pressure 44, you can see the narrowing of the sinus. They draw down the pressure to 16 and they repeat the MR venogram and it opens. And then at 22, it starts appearing again, and then it goes away and comes back. And so we used to do an MRI, MRV after lumbar puncture to see if it would open or close. But now I don't do this anymore. I just think it doesn't matter whether it's the chicken or the egg. We're going to be thinking about stenting the sinus. And there's all sorts of abnormalities that can be seen on the MR venogram that can be graded. The ones you have to worry about are make sure it's not venous sinus thrombosis, make sure it's not a dural venous fistula, and then if it's stenotic, is it hypoplastic or is it a true acquired stenosis? And that you need to work with your neuroradiologist locally on, because it's difficult sometimes to tell a hypoplastic sinus from a venous sinus acquired stenosis. And of course, 90% of patients with IIH have this transverse sinus that appears stenotic on either time of flight or phase contrast MR venography. I prefer the contrasted version because it eliminates a lot of the artifacts associated with a non-contrast time of flight or phase contrast MR venogram. If they come to me with an MRI but no MR venogram, if it's a typical demographic, quacks like a duck, looks like a duck, flies like a duck, I don't make them have an MR venogram. But if there's anything atypical about it or they're getting worse, I'm going to do the MR venogram. If they're a man, thin or old, or a kid, we're doing an MR venogram. If they're on the birth control pill, we're doing an MR venogram. And as I mentioned, the MRV after the LP can show that it's a Starling resistor, but maybe it doesn't matter. Just stent it. So when do I personally recommend a venous sinus stenting procedure for idiopathic intracranial hypertension? We have to have the venous sinus stenosis on the MR venogram. We have to have a pressure gradient of 9 or more across the stenotic segment on venography, invasive catheter angiogram. And I think you should at least try maximal medical therapy. Or if the person's a poor candidate for or cannot have any of the other surgeries, the shunting procedure or the sheath fenestration. And meta-analysis suggests that stent actually might be better, even though we don't have a real head-to-head trial, stent versus sheath versus shunting. It's really becoming the go-to top of mind for a lot of these patients. And so even though the question used to be which came first, the chicken or the egg, does venous sinus stenosis cause increased ICP, the chicken, or does increased ICP compress the vein, the egg? Maybe it doesn't matter. You should know, however, that the egg came first. Dinosaurs had eggs and dinosaur became the modern chicken. So idiopathic intracranial hypertension, of course, is a diagnosis of exclusion. That's why we have the modified Dandy criteria: young, obese female, normal MRI, MRV, normal CSF, elevated opening pressure. The atypical cases: thin, elderly, male, progressive, or if they have any other sign or symptom that cannot be directly attributed to increased intracranial pressure. And the other reason you need ophthalmology is for us to make sure there's no intraocular inflammation, uveitis, anterior or posterior, that does not occur in IIH. So here's a 14-year-old thin African-American female sent with papilledema, MRI scan negative, LP opening pressure 31, CSF normal. And so when you have a kid, childhood IIH looks a little bit different than adult IIH. They're more likely to be secondary, so you have to ask about those medications: lithium, tetracycline, nalidixic acid, vitamin A analogs. The most common secondary medication-induced ones that we see in kids are the acne medicines. The BMI doesn't matter as much, so you can be thin, but once they get to puberty, it probably matches the adult version in terms of demographics. In children, there's no gender predilection, and we generally allow a higher intracranial pressure, maybe as high as 28 for a kid. So in pediatric IIH, the modified Dandy criteria have been modified. So there's a modified Dandy criteria for kids. And the main issue is the 28 centimeters of water. And in neonates, of course, they have this immature system, so they can have a few white cells. Everything else is pretty much the same. Although kids can have other cranial neuropathies, it's a diagnosis of exclusion. So which of these patients should you worry about if you're making the diagnosis of idiopathic intracranial hypertension? You should worry if it's a kid. You should worry if it's a thin male. You should worry if it's a male or elderly patient. So elderly, male, thin, or kid, you should worry. If it's obese female of childbearing age, you should also worry about venous sinus thrombosis, but you're not as worried. And so the typical case, overweight, young female papilledema, symptoms of headache, pulse synchronous tinnitus. A CT might be okay in the first initial evaluation, but you need to have an MRI, MR venogram. And if it's atypical, full court press on that patient, MR plus MR venogram. We mentioned the treatment, of course, diet for everybody. Acetylxylamide was shown to be effective in the idiopathic intracranial hypertension treatment trial. Our second line agent is furosemide, Lasix, and topiramate is our third line agent. And if you need surgery, sheath fenestration and shunting, but stenting is coming along. The controversies were that acetylxylamide was not subjected to a randomized trial before, but now that's something new. IIHT showed Diamox is effective, but the other agents are not proven. So those second line agents have not been subjected to a randomized trial. Topamax theoretically would work because it causes weight loss and can treat the headache, but it has significant side effects, and there's no cure for pseudotumor cerebri. You should know that sulfa allergy isn't really a sulfa allergy. It's not an IgE-mediated anaphylaxis. So if people say they're allergic to sulfa, they're not actually allergic to the sulfa moiety. Sulfa allergic people are allergic people, however, so you should worry about allergy to any medicine, including penicillin. The thing you're allergic to in sulfonamide antimicrobial true IgE reactions is the N-arylamine group, that is the hapten. And sulfonamide antimicrobials, once you have an event from allergy, that's a true cross-reactivity class effect, and so you can't get other sulfonamide antimicrobials. However, you should receive, you can receive other sulfa-containing agents. And so here is the sulfonamide antimicrobial agent, and you cannot have any of these drugs in the same class of sulfonamide antimicrobial if you have this hapten, the N-arylamine group. There's low risk of cross-reaction, however, but we give the patients a test dose for things that are sulfonamide non-antimicrobial agents, non-antibiotic, and there's no risk for sulfates, sulfites, or sulfur because you're not actually allergic to sulfur. So Diamox does not have the hapten for the immunologic reaction, which is this N-arylamine group. Only sulfonamide antimicrobials have that. So sulfa allergy, it's probably not a big deal. Sulfonamide antimicrobials do not cross-react with sulfur-containing agents because the sulfa moiety isn't the problem. Furosemide, also a sulfa agent. I give them a trial in the waiting room because they're allergic people. It's probably more for medical legal than medical reasons. So to this point, I hopefully have emphasized to you the issues and the pitfalls are you have to look for papilledema in every patient with symptoms of increased intracranial pressure. And for a neurologist, that means you really need to partner with an ophthalmologist. You need to check their blood pressure. You have to do a contrast MRI, head and orbit, with a contrast MR venogram. Of course, you have to measure the opening pressure and do the CSF with the lumbar puncture, even though there's some people that say you can get away without an LP. I'm not one of those people. And you need to recognize the severe, acute, and fulminant version of this thing, and that thing is called fulminant IIH. So here is a 7-year-old girl. She had bilateral disc edema, macular star figure. She was told by retina that she had bilateral neuroretinitis, infectious, but the CAT scratch titer came back 2 weeks later. She had an esotropia, which they interpreted as a sensory esotropia. And the rest of the story is she had an MRI and it was a tumor. It was actually a medulloblastoma in her posterior fossa. So what went wrong? Bilateral disc edema with a macular star figure is not diagnostic for infectious neuroretinitis, and papilledema can produce that macular star figure of exudate and can totally mimic optic disc edema with a macular star figure. So you should image all bilateral disc edema patients, even if you think it's infectious neuroretinitis. This is a 12-year-old girl who had recurrent UTIs. She also had bilateral disc edema. An MRI was negative. A lumbar puncture showed normal CSF, and she was started on azelaidomide. However, they didn't check the blood pressure. You need to check the blood pressure on every patient with papilledema, even if it's a kid. And in this case, of course, it was urinary tract infections leading to renovascular hypertension from hydronephrosis of the kidney. And kids can get hypertension too. It can totally mimic papilledema. This is a 25-year-old thin male who has headache. They noted the papilledema. They did the non-contrast CT. LP in the ER was normal. They started on Diamox. He was treated for 6 months, but wasn't any better. And of course, the torcular meningioma. So this is the most common meningioma that I see causing this, by the way. Torcular meningioma, vein of Galen meningioma, superior sagittal sinus meningioma. We probably have 4 or 5 of these cases now. Often they are atypical presentations, either the wrong demographic or a thin person. But 2 of the patients that had a meningioma were in the right demographic, obese, white female, BMI 30. So you need to order an MRI with an MR venogram. And this is an 18-year-old woman who had headache for 3 weeks before Christmas. First visit, normal CAT scan, discharge migraine, headache increasing, ER visit number 2. CSF was done, no opening pressure. Now you're 1 week before Christmas. Christmas Eve, this is ER visit number 3. 3 strikes and you're out. She now has diplopia, blurred vision. Finally, ophthalmology is called. They say come to the clinic on Monday, but she goes blind on Sunday. Sees the second ophthalmologist who notes the papilledema, and that thing is fulminant IIH. She's now count fingers vision, and despite bilateral optic nerve sheath fenestration, is blind. The second ophthalmologist unfortunately tells the patient, if only you come to me sooner, we might have been able to save your vision. And at that particular moment in time, they're thinking this, 1-800-LAWYER. So please don't do too little too late. The thing that is too little too late is too little medicine and too little surgery for fulminant IIH. Fulminant IIH is defined as acute and severe. Acute, less than 4 weeks of symptom onset. Severe, loss of acuity or significant loss of visual field. And as you know, in the IIHT, they defined mild to moderate decibel loss on the Humphrey as -2 to -7. So once you start getting to double-digit decibel loss, and it's less than 4 weeks, that's fulminant. So all of these patients have IIH. Some of them have big blind spots. Some of them have big blind spot plus inferior nasal stab. But the one that needs the knife is F. F needs surgery if they have failed maximal medical therapy. So in the algorithm, yes, IIH, modifying Dandy criteria, lose weight. If there's no immediate threat to vision, you can do Diamox, 500 milligrams twice a day. You're going to treat their headache. And if they get worse on maximal medical therapy, you do surgery. However, this is the one I want to emphasize to you, the acute and severe version of it called fulminant IIH. Admit to the hospital, neurosurgery to place a temporizing lumbar drain, and then you're going to make a decision about sheath, shunt, or stent in that hospitalization. Because sometimes patients just need hot lights and cold steel to touch them. There is no version of this game operation where you pour Diamox down that funny bone. It needs surgery. So what went wrong? Papilledema doesn't normally cause acuity loss. Once you have acuity loss, you need the knife. They usually show peripheral field loss, but some patients lose their vision rapidly and emergently, acute and severe. That's called fulminant IIH. We're going to put a temporizing lumbar drain and get ready for operation. Sheath, stent, shunt. Earlier diagnosis and treatment definitely makes a difference in fulminant IIH, and the standard of care does not change based on whether it's a holiday or weekend. Please don't tell the person to come on Monday if they have fulminant IIH because they'll be blind on Sunday. Shunt versus sheath fenestration, probably equivalent efficacy. There's clearly a more morbidity for neurosurgical procedures like shunting, regardless of whether it's a ventriculoperitoneal, a lumboperitoneal shunt. Programmable valve, VP shunt is our preferred at our hospital. They all fail. Half of them are broken within the first 5 years. You're just trying to temporize the person. Sheath fenestration in our hospital is a better option if papilledema-related vision loss is the primary indication. Neither is a cure, and stent is actually probably rising above both of these options now. So when do I do the shunt or sheath fenestration? They have to have progressive vision loss that fails maximum medical therapy, or they presented with the acute and severe form fulminant IH. If the vision loss is the main indication, I favor sheath fenestration. If it's intractable headache and they failed maximum medical therapy, including maximum headache therapy, programmable valve VP shunt. But I let the neurosurgeons, because we have 2 vascular neurosurgeons now, decide about stent versus shunt if we're to that stage. You need to talk to your own surgeons locally. And clearly, with the obesity epidemic that has come to my town and to your town, there's going to be more shunts. And you can see the number of shunts rising from 1998 to 2002 in neurosurgery. Sheath fenestration is flat. So some stenting might be the answer here. Bariatric surgery, a great long-term cure for IIH because weight loss is the best long-term treatment, but bariatric surgery has its own complications, including vitamin deficiencies. If you look at ventricular shunts and lumbar shunts in that neurosurgery paper, 0.9% inpatient mortality for the VP shunt, and lumbar shunt, 0.3% inpatient for a disease that really doesn't kill anybody. So literally these people died from having IIH. To my knowledge, nobody's died from a sheath fenestration. You need to know about the last thing, which is something blue. That's obstructive sleep apnea. Clearly, there's a relationship between papilledema and IIH, a combination of increased ICP secondary to hypercapnia, leading to cerebral vasodilation. And the reason you need to know about it in the diagnostic side is sometimes the opening pressure in the daytime is normal, but they have all the symptoms, radiographic signs. And if they have papilledema, you pretty much should treat them. In this retrospective review of men, the atypical demographic, intracranial hypertension in men, obstructive sleep apnea was the most common comorbidity. And the daytime lumbar puncture opening pressure in these patients was often normal. And just treating the sleep apnea improved the symptoms and the signs in these patients. And so at the end here, the obesity epidemic is here. It's here for me. It's here for my children. And so drag your kid away from that computer. I try and practice what I preach. So I have a treadmill in my office, and I use it every day during morning report. So in summary, hopefully I've been able to review for you the basics of idiopathic intracranial hypertension and something old, the modified Dandy criteria. Describe the relatively recent IIHT, which proved in a randomized controlled clinical trial that acetazolamide did the thing we thought it did, lowered the pressure, improved freezing grade, and improved vision. And so it's something relatively new. I've described to you something we borrowed from endovascular, which is stenting. The Starling resistor is that venous sinus stenosis. And maybe it doesn't matter whether it's the chicken or the egg. A stent could be vision saving and might actually be better than a shunt or a sheath fenestration. We're still awaiting the head-to-head trial, however. And then something blue. We always administer the Berlin or whatever questionnaire we have for sleep apnea, especially in male patients. And treating the obstructive sleep apnea is important. I just want to end with the moral of the story, which is how you, as an individual doctor, make a difference in the lives of people by showing you how mentorship works. The story is about a state called Iowa. I used to work at the University of Iowa, and as you know, I kept my academic appointment there. Iowa only has 3.4 million people in the whole state. Houston, Texas is twice the size of the entire state of Iowa. This is Norman Borlaug. He's the most famous person you've never heard of. He was born in that little state, Crestor, Iowa, 1914. He won the Nobel Peace Prize in 1970 for developing wheat and corn hybrids that could grow in arid climates. That's not the cool part. The Borlaug Green Revolution allowed high-yield dwarf pest-resistant wheat strains to increase yield. It yielded 2 to 6 times more grain. Pakistan went from 4.6 to 8.4 million tons of wheat. India, 12.3 to 20 million tons. Mexico, 6-fold increase. and went from a net importer of wheat to a net exporter of wheat in 1963. You can see here the wheat yields before and after the Borlaug Green Revolution. This is the wheat yield in Mexico, India, Pakistan, pre-Borlaug, post-Borlaug. But there would be no Borlaug without Henry Wallace. Henry Wallace, also from that little state, Iowa. He was the agricultural secretary and later became the vice president of the United States under Franklin Delano Roosevelt. In 1940, Henry Wallace, the ag secretary and VP, vacationed in Mexico. And he said, you know, the corn here in Mexico just isn't as good as the corn in my home state, Iowa. I've got an idea. Let's start an agricultural experiment station so we can test whether we can make corn grow here in Mexico. Norman Borlaug was selected to be that agricultural station's first director. Bruce Alberts, president of the National Academy of Sciences, said this about Norman Borlaug. Borlaug may have saved more human lives than any other person in history. He prevented worldwide famine and saved an estimated 1 billion lives on planet Earth. That's still not the cool part. Somebody influenced Henry Wallace. As a 6-year-old, Henry Wallace used to take walks with a student at Iowa State University. That student's name, George Washington Carver. This is what Henry Wallace, the future ag secretary, said about George Washington Carver. His faith in me aroused in me a natural instinct to excel and deepened my appreciation of plants in a way I can never forget. Yes, that George Washington Carver. He was born a slave, orphaned in infancy. His mother was kidnapped by slavers when he was a kid. He never saw her again. He did not get an education because of the color of his skin. He did not even start school until age 12. George Washington Carver trained in Iowa. He was the first Black student at Simpson College in Iowa. He was sent there to study art and piano. But one of his professors there, Etta Mae Budd, recognized the potential of the young man and helped him find gardening jobs to work his way through school. She noticed that he was really great with plants and encouraged him to study plants rather than painting them. Her father was professor and chair of horticulture at Iowa State and helped George Washington Carver transfer there, where he became the first Black student and the first Black teacher at Iowa State before going on to Tuskegee. Why am I telling you this at the end of a story about IIH and obesity? You might not be Norman Borlaug. I know I'm not. You might not even be George Washington Carver. You will not be the Vice President of the United States, Henry Wallace. But you can be, you should be, you are Etta Mae Budd to somebody. Etta Mae Budd recognized the value of George Washington Carver, who walked hand in hand with a Henry Wallace, who founded the agricultural station and selected Norman Borlaug to save 1 billion people. So at the end here, what's really the most important part of my life and your life? Clinical care, research, education. Really, it's about finding and being the right mentor. It is mentorship and education that is our future. I believe in all of these things, but I think mentorship is why I'm here. Education is why I'm here. I believe this. I have had many mentors and many Etta Mae Budds in my lifetime. And it's not just about medicine. These are my daughters, Rachel and Virginia. They are now 21 and 19. Etta Mae Budd lives in me. And I thank you for your time and attention, and I'd be happy to answer any questions you might have at this time about IIH and the obesity epidemic that is coming to your town.
Wow. Questions? Yes, sir.
Great talk, Dr. Lee. I was wondering if you could elaborate on the aspect of social determinants of health. When you showed those maps, those were countries that used to be undernourished. And what you're talking about is a disease that might be related to overnutrition.
For sure. So it's the same problem in our country. Literally, there are pockets of food deserts in our country where you can only get fast food or you can only get junk food. And those food deserts are not areas where you would think they would be skinny. They are obese. So the food desert, ironically, creates obesity. So it's not a calorie problem. It's a nutritional problem. And so, yeah, obesity is partially derived from these social determinants. And then the map of the world, you saw those countries didn't have this before. And so those populations are particularly vulnerable. And in our own country, that's the Native American populations, Hispanics, African Americans, way disproportionately affected by the obesity epidemic, and in girls. So it is the demographic itself is vulnerable population. So I appreciate your comment.
Just asking about the amount of weight loss that needs to happen. We talk about weight loss, but it's supposed to be like 10, 15, 20%, right? It's not 5 pounds.
Actually, the data shows that we only need about 6 to 8%. So I always emphasize that to the people because they've tried to lose weight before. So I tell them, look, you don't have to be skinny. You only have to lose 6 to 8%. And it's amazing how just coaching and having the goal be smaller is much more effective than just saying lose weight. So we actually don't need that much weight loss. 6%.
So, great talk, thank you. Wondering what you think about the role is for semaglutide or other medications for weight loss. I mean, I'm a stroke neurologist. I struggle with this in my own practice. It's not something I've become comfortable with, but I feel like it may be something that we need to think about for these diseases that are related to obesity as an option.
For sure. Of course, it hasn't been subjected to a randomized trial yet, but semaglutides and the GLP-1 medications definitely work for weight loss, and weight loss is the best long-term treatment. What's amazing about the GLP drugs is they also lower intracranial pressure. So believe it or not, they had patients on these agents and they had a Bolt intracranial pressure monitor in the person, and just taking the medicine lowered their pressure independent of their weight loss. So I think the agents have tremendous promise both for addressing the root cause, but probably also something to do with the pathogenesis of the disorder. And as you know, idiopathic is still idiopathic, even though Dandy has been dead a long time. So yeah, I think it's coming. A clinical trial for just the semaglutide and the other GLP agents in IIH. It's coming.
Any questions? I have a final question. We had a patient who looked like, who had a typical phenotype for IIH, but when we did the LP, the opening pressure was something like 21 and 22. And then the question of normal pressure IIH was brought in. What are your thoughts about that?
Yeah, so as you know, the pressure can fluctuate and there's diurnal. And so I would treat the patient, not the pressure. So if they have papilledema, who cares what the pressure is? 20 to 25 is actually what we consider borderline. So it's kind of like glaucoma for the eye, except it's glaucoma of the brain. We have these normal pressure glaucoma people, normal tension glaucoma. And so the pressure is like a bell curve. So there's clearly people who have high pressure and there's nothing wrong with them. And there's people that have low pressure or normal pressure and they still have pseudotumor cerebri. So what the pressure number means is between the 5th and 95th percentile is most people. But then there's this 5% who are 2 standard deviations from the mean. That doesn't tell you whether they're normal or abnormal. It just tells you that their pressure is normal or abnormal. And so if the person has clearly papilledema, has symptoms of increased ICP, signs of increased ICP, and the radiographic signs of ICP, if the pressure isn't that high, they still have the diagnosis because the post-test likelihood of disease is still so high. So pre-test likelihood of disease is a way more powerful predictor of post-test likelihood of disease than the test. And if the test is bad, throw away the test. If the test is equivocal, throw away the test. Doctors make diagnoses, not those tests.
Absolutely. Well, thank you so much for giving this talk. It was an honor to have you here. And thank you again. And hopefully you can do this maybe next year as well. Thank you.
Anytime. Thanks for having me. Bye.